Hi, everyone. Yeah, louder. All right. Okay, welcome everyone to our Department of OBGYN Grand Rounds. Hi, good morning. So wonderful to see so many faces in person here. We're at the Topaz Room. It sounds very fancy. This is in our Gladys Vision Center. We're really trying to make this our home for our in-person Grand Rounds, as this is also our home for our office buildings, for our department. So we're really excited to welcome you here. And I'm so excited to have our speakers who Dr. Robertson will introduce. But to start off, I wanted to start with our land acknowledgement. We'd like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon their home. And we're proud to continue their tradition of coming together and growing as a community. And we thank the Ramaytush Ohlone community for their stewardship and support. And we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And if you'd like to learn more about how to support the Ramaytush Ohlone people and know their history and background, please look at the chat as well as the links up here. And then I'd like to introduce Dr. Robertson.
Morning. It's my honor to introduce Dr. Hayley Miller and Stacey Fletcher today for their grand rounds. How perfectly timed is this? This month is Pregnancy and Infant Loss Awareness Month. Dr. Hayley Miller is a maternal-fetal medicine specialist at UCSF with a special interest in stillborn care and pregnancy after loss. She completed her residency and fellowship at Stanford University, where she led multiple research and quality improvement initiatives focusing on advancing care for families experiencing stillbirth. She is actively involved in policy and advocacy through her work with ACOG and the Society for Maternal-Fetal Medicine. She serves as ACOG's early career physician representative for California, is chair of the ACOG Committee on Public Health, and a member of both the ACOG Committee on State Legislation and SMFM Health Policy and Advocacy Committee. She has recently been selected to serve on the ACOG Board of Directors, which we're very proud. At UCSF, Dr. Miller leads the Pregnancy After Loss Clinic and collaborates with the U.S. Pregnancy After Loss Network with the goal of fostering research partnerships and advancing high-quality, compassionate care for the perinatal loss community. In order to get this program running at UCSF, she has navigated many committees, phone calls, IT issues, grant applications, and the usual barriers to new programming with incredible skill and patience. What she has accomplished after being on our faculty for just 1 year is truly exceptional. Stacey Fletcher is the program manager for Parent Voice of the UPAL Stillbirth Center of Excellence. As a clinical trainer and peer support specialist for the Utah Pregnancy After Loss program, her position ensures that parent experience plays a key role in developing excellent physical and mental health. She is honored to share her lived experience of deep grief and extensive rebuilding following the stillbirth of her son, Benjamin, 18 years ago. Stacey advocates for and participates in stillbirth research, equitable bereavement care, and community awareness. She has presented her perspective nationally and internationally, promoting the important role of parents in stillbirth prevention and sensitive clinical care. She has spent many tender hours with families in hospital rooms, mortuaries, and homes. She is a storyteller. She has worked professionally as a writer, editor, educator, and publisher. She is passionate about giving voice to others. Stacey and her husband, Brian, are the parents of 5 living children. Together, their family advocates against the racism and disparities often found in underserved and marginalized community. We welcome Dr. Miller and Stacey and look forward to learning from you both.
All right, what a warm welcome. Thank you, Dr. Robertson, and thank you everybody for coming today so bright and early. So I have no disclosures and Stacey does not either, but I do want to acknowledge a recent grant that I received from the UCSF Division of Maternal-Fetal Medicine, and this was the MFM Junior Faculty for funding my time visiting the various pregnancy after loss clinics and for launching my research database to advance this work. So the objectives of this talk is really for everybody to understand the workup for stillbirth and really also delivering compassionate care that I know all of us do. The first slide, I really just want to hold space for a compassionate conversation. And I hope people in the audience will just walk away with some clinical pearls to improving the assessment and management of stillbirth, and to also just acknowledge all of us who are involved in a very emotionally challenging spectrum of obstetric care. And in this talk, there are going to be some photos. So if anybody needs to walk away or take a moment, we also acknowledge and respect that. So just some background and statistics. The incidence of stillbirth, as you can see here, has overall decreased from 1990 by about 26%. But since 2019, so the last 6 years, it's been relatively stagnant. Currently in the United States, there's 1 in 175 pregnancies are affected by stillbirth. So at UCSF, we deliver 2,500, 3,000 pregnancies. And so 1 in 175 of those will result in a stillbirth. So this is something that we all see very frequently, but sometimes not frequently enough to really feel confident in our skills for providing compassionate and quality care. So the US rate is higher than the majority of high income countries. US stillbirths outnumber deaths of children aged 1 to 14 from all causes. California, we're doing okay. Our stillbirth rate were 5 for 1,000 live births, and we've had overall a decline by 6% from 2021 to 2022. With all of these statistics, I do want to introduce, after Dr. Robertson, introduce Stacey Fletcher, because as we said, the parent voice is incredibly meaningful, and I just want her to tell you all a little bit about her.
It's an honor to be here with you today. The reason that I'm here is because of this little guy. His name was Benjamin, and he passed away. He was full-term stillbirth 18 years ago with no cause found. I have 5 living children now. We've adopted 2 daughters after the death of Benjamin, and Benjamin's really what got me into this work, but my daughters are what keep me in this work, because Black women are twice as likely to have a stillbirth as a white woman. And so I want to acknowledge 18 years ago when I walked into that hospital room, I walked in as a white, straight, married, higher income woman, and not everyone has that privilege, and I recognize that privilege. So I want to talk a minute about our Pregnancy After Loss Network. Why do we need this model of care? What makes it important? And how do we help these families? Families who lose a baby and come back in a pregnancy after loss have increased psychological, emotional, social challenges, and increased pregnancy problems. They need additional support and interventions to help them during their subsequent pregnancies. And they have a higher risk for preeclampsia, placental abruption, low birth weight, preterm birth, or NICU admission. And we'll talk a little bit more about that. They have an increased risk in complications and are twice as likely to have another stillbirth. So the International Rainbow Clinic Network started about 2 years ago with Dr. Alex Heasel and Claire Story out of the UK. He has 30 plus clinics in the UK that he operates, and he's seen phenomenal success with his clinics, not only in his stillbirth rates, but also in patient satisfaction. He has clinics all over the world, actually. The US is one, Australia, the Netherlands, Ireland, and we're working on a clinic in Rwanda. And under the US Pregnancy After Loss Network in the US, the first clinic to open was Mount Sinai with Dr. Joanne Stone. Columbia University was second with Uma Reddy. Third was the University of Utah, where I work with Dr. Bob Silver. We're funded and motivated by the Natalie Foundation with the Sheridans. They've been, just the foundation of getting this up and running, and also the Iris Fund with Brittany Crystal. They are both lost moms and families, and the clinic is amazing. UCSF is our first clinic to go online with our training, and Dr. Miller and her team have been phenomenal to work with. And so they are ready to go. We're already looking at research, and really cool what they're doing. We have UCLA coming online, Yale, Penn State, Intermountain Health, another clinic in Utah, and the University of Hawaii are all involved. So this is a huge organization with a lot of opportunities for collaborative work globally and nationally. So what is a UPAL clinic? We have criteria that these clinics need to meet in order to follow under our network. We accept all patients. We have multidisciplinary care teams, specialized training, which we're receiving today and this week, standardized protocol, which I think is so important, access to mental health. Mental health is taken very seriously as much as physical health often in our pregnancy after loss clinics, and the data sharing agreement. So we can share data and research nationally, globally, and some genetic research has started with Dr. Miller already. The approval is given by the big three, we call them, Bob, Joanne, and Uma, and then they are officially under the Rainbow Clinic Network. So it's important.
So just a little bit about the UCSF Pregnancy After Loss Clinic is just our patient population and who we see. So our patient population includes people who are postpartum in the preconception period, and also people who are pregnant again after their loss. The main focus is stillbirth, neonatal death, and termination of pregnancy for medical reasons or for any reason that a woman would like to be seen in this clinic or person. And additionally, other patient populations are people with recurrent pregnancy loss between 16 and 20 weeks, preterm birth, recurrent, or other types of pregnancy loss as well. And part of this care is we provide longitudinal care with the same provider, or we work with a multidisciplinary team. I work very frequently with the midwife team, nurse practitioners, other OBs, and this is for patients who might not just want to see me throughout pregnancy or are the other providers who are in this clinic, but people who also want to be seen by other types of providers as well. We work closely with mental health support in providing appropriate referrals, and we provide guidance on obstetric, imaging, cadence, and antenatal testing. And also just a part of this network is we've realized that a lot of these patients who are pregnant after a loss have a lot of anxiety, and every ultrasound really matters to them. So we provide informal ultrasounds at every visit if the patient does prefer that. We also have patient consultations. So this is for people who have had their loss, and we see them in the immediate postpartum period to evaluate all of their workup that they have received. And additionally, we also see people in the preconception period as well. I've been working with our genetic counselors, and we're also having a joint clinic with myself and Holly, who, because we've noticed that really putting people through the same interview in multiple different arenas is really challenging. So we're now creating a collaborative clinic to really just have the patient go through their story once. We provide preconception counseling and then discuss management plan for their subsequent pregnancy, including conception timing, medications that may or may not be indicated, antenatal testing, and delivery timing. How to refer. So this is for everybody in the room and on Zoom is we have now used our umbrella for how to refer. So our referral to obstetrics and gynecology. And then as you can see here, the high risk obstetrics, and then we have a pregnancy after loss button. So when patients are being discharged, I recognize that many people in this room take care of patients who have had a stillbirth or neonatal loss, and please continue taking care of your patients. But this is really intended for a specialty clinic, and if you want them to see me or my colleagues who are working closely with me. In terms of mental health resources, this is a huge component of this clinic, and we really are striving to improve our mental health services that we're providing. So the big thing is, especially after people are discharged, is referring them to our pediatric pain, palliative, and integrative medicine. So Summer Siegel is a grief counselor here at UCSF, and she provides grief counseling after a patient has had a loss for any reason. And so placing a referral at the time of discharge is incredibly helpful, or if you meet this person in the postpartum period in clinic. We also have a UCSF website, First Pregnancy After Loss. So this is a website that we actually houses organizations both at UCSF locally, there's HAND, which is a in-person support group for people with loss. And then additionally, we have podcasts, books, movies for patients who've had loss. And we have categorized it by supporting the birthing person, the partner, and children also that are in the family of a person with a loss as well. These are just some of our local organizations that we have at UCSF for both Black identifying patients and all patients as well. And these are for people immediately in the postpartum and even in the pregnancy after their loss. So one thing that we've worked closely actually with, we've learned a lot from Utah, and we really have realized that identifying these patients is incredibly important because these patients are coming in to triage, they're coming in to antenatal testing, they're the ultrasound unit, and these patients who are pregnant again really have experienced trauma, some are still experiencing PTSD, and really we want to make sure that we're identifying these patients to help improve their experience in their next pregnancy. So we've included in the problem list in EPIC, a pregnancy after loss problem here. And then we have a smart phrase to use to really identify these patients and help contextualize their patient scenario. So it's just a brief sentence here to contextualize how their loss happened, how the patient refers to their loss. Some people want to use the name that they had chosen for their previous pregnancy, and they want us to say their name and use their name. That is their baby, and that is their baby's name, and they really want to talk about it like that. And some patients that I have say, I just want to refer to it as my previous pregnancy. So we have this here, and we really hope that people look at this problem list and use it to help the patient in their next pregnancy. The gestational age, triggers, and methods of reassurance. Some patients say that they don't want to deliver in the same or near the same room that they delivered their loss in. Some patients really had a fetal anomaly or a fetal brain bleed. And every time we put an ultrasound probe on that particular part of the body, we just want everyone to be aware of how much stress and anxiety this can cause. So really looking at this and using this in the next pregnancy to just provide some reassurance to all of these patients. Additionally, we have the leaf icon. I think many people have seen this, and this is an icon to identify patients with a loss. Unfortunately, the leaf disappears after 12 months, and we all know that after 12 months, these feelings don't just heal. So we're working with our EPIC folks to advance this icon and really advance our whole EPIC identification. And a group of us are also working on AVS for discharge instructions for patients who are leaving labor and delivery following a stillbirth, which will include mental health resources and other resources for lactation, because I know that we oftentimes give cabergoline, but there are patients who also desire milk donation. So we're providing all of these resources in one AVS, which we know many patients will never read, but we just want patients to really walk away with all of the information that they need. I want to briefly talk about risk factors. We know that stillbirth rates are increased in Black identifying and Native Hawaiian and Pacific Islander communities. We know that race is a risk factor. Racism is a risk factor, and not race and ethnicity on their own. Stillbirth is really increased in a bimodal distribution, so under 15, and we take care of many people who are 45 and older. So this is a risk factor, and really ordering antenatal testing for these patients. And then we're seeing increasing rates of elevated BMI. So also understanding that BMI is a risk factor. ACOG recommends antenatal testing for anyone between a BMI of 35 and 39, starting at 37 weeks. And then greater than 40 weeks, we really should be offering antenatal testing or recommending antenatal testing weekly, starting at 34 weeks. This is a list of all of the conditions that many of us see very routinely. So just to name some: chronic hypertension, diabetes, uncontrolled thyroid disorders. And then many we see is IVF can increase your risk of stillbirth by 4-fold for singletons. I have some of the etiologies here. We see some of the causes of stillbirth. And I like this graph because it goes through the different gestational ages and the different reasons. And I think what really draws me here is that, as you can see, gestational ages 24 weeks and beyond, 25% remain unexplained. And the reason why I bring this up is because we can improve this rate by providing the appropriate workup for all of our patients who've experienced stillbirth. So this is a list here that every single patient with a stillbirth should have ordered for them at the time when they're in labor and delivery. And I'll walk you through exactly how to order all of these things here at UCSF. The percentage listed is the yield that contributes to the etiology of stillbirth. So I have bolded here placental histology, but I also should have bolded clinical history, because it's really important that everybody talk to their patient about risk factors or risk factors and other just clinical history that would be important to the workup of stillbirth. Additionally, I'll go through all of these separately, but autopsy, genetics, antiphospholipid antibodies, fetal maternal hemorrhage, the KB test, and syphilis. We know that syphilis is increasing both locally, statewide, nationally, and every single person should actually have a recent RPR testing in their pregnancy if they've had a stillbirth. So there is room for ordering other tests. Again, this is where clinical history comes in, but really this should be limited for different specific clinical scenarios, which is including testing for specific infections, glucose screening, for example, if a fetus is macrosomic, or thyroid testing if there is evidence of thyroid disease. What's not useful in the literature is placental cultures, routine torch titers, ANA testing, testing for large numbers of thrombophilias, bile acids, toxicology. Toxicology should never reflexively be ordered, and we know that it still is at times, not here, but it is, I still see this ordered, and this really should not be ordered. We know that patients who use substances tell us that they use substances, and this should not be ordered as a part of the stillbirth workup. So this is just to introduce you all to our Apex admission order set. So when patients come to L&D, this should always be ordered because this has all of the labs that are appropriate for the stillbirth workup. So including all of the antiphospholipid antibodies, we have our KB test down here, and then we also have an RPR testing that was hard to screenshot everything the same. And then additionally, we have our surgical pathology and our genetic testing, which I'll go into. In terms of placental pathology, this is a gross and microscopic examination of the placenta, umbilical cord, and fetal membranes by a trained pathologist. And this is the single most useful aspect of the evaluation. And the reason why I say this is not only just to order this, but to also talk to your patients about this. You know, a lot of patients really don't, after this, they're in shock. They don't know what to order. They don't know what is really necessary for the workup. So just telling your patient, like, this really is the single most useful test if we're going to order anything. Here at UCSF, Dr. Gonzalez and myself have really been working with our pathology department to advance this work. We've noticed that after patients or people have been able to see their records, the pathology reports started getting a little bit more slim. So we've been working with our pathology departments that all of their reports are really important to understand not only the etiology, but maybe how to prevent a recurrent stillbirth as well. And they've asked that we actually help them recognize which placenta really is with a stillbirth, because we know that it's important. So we have this automatically filled in to our order set, which is stillbirth of unknown etiology, assess placenta for potential etiology. So we have this written into our order set. You don't need to do anything, but we just want to make sure that this is always there when the placenta is ordered. Additionally, I just wanted to add briefly is that the pathology department will assess the placental umbilical cord. So just leaving some length of the umbilical cord when you're sending this to pathology. Sometimes we reflexively, if a baby is born after a stillbirth, if there's a nuchal cord, we tell the patient immediately, oh, it's because there's a cord accident. They'll actually assess the umbilical cord, and they'll examine it for edema, congestion, thrombosis. Because I just want to note that nuchal cords occur in 30% of uncomplicated pregnancies. So this might not always be the etiology. There might be other etiologies. So really when patients come in, they hang on to every word that we say. So maybe pausing and allowing the full workup to result before we tell a patient, this is what happened, this is what caused it. In terms of autopsy, the autopsy reviews the medical record, weights, external examination, and also a microscopic examination. This is a picture of a pathologist at UCSD who recently received an NIH grant for her funding and advancing stillbirth work. I just wanted to note that autopsy is a very challenging conversation, which Stacey is actually going to help navigate us through in a bit. And the reason why I bring this up is because there was a recent study that showed 64% of patients were offered an autopsy. So on the contrary, 36% of people were not offered an autopsy. And the uptake has decreased by 35 to 48% since the 1990s. So we know that this is a test that can contribute to the etiology, and it's just something people aren't even getting offered. If people do not want an autopsy for cultural, spiritual, patient preference, we also order post-mortem imaging, and this is something that we can do here, and this is actually embedded in our order set. And this is an fetal MRI, and we know that studies have showed that a fetal MRI is between 80 to 95% concordant with a traditional autopsy. So if a patient does not want an autopsy for a traditional autopsy for any reason, this really should be offered to the patient as well, because we know that it can help. Of course, the sensitivity depends on the system of the body, as you can see here, but it still is worthwhile to order this or to offer this when a patient declines an autopsy, a traditional autopsy. For genetic assessment, we have a robust genetic counseling team. We offer a very comprehensive genetic assessment. And here we just want to say that their patients are ordered either a karyotype or chromosomal microarray. However, this is ordered through the DNA extraction. So this is to whole DNA, and this helps navigate our genetic counselors to order either additional testing or to just counsel our patients for chromosomal microarrays. The reason why I bring this up is because every single patient should get ordered this DNA extraction and hold, and additionally a discharge referral for genetic counseling at the time of their stillbirth. And this should be sent for all patients. And the reason why I say this is because some patients are in shock after their stillbirth. They don't know if they want genetics. Sometimes they are unsure what this even means. They need time to process, or sometimes they come in labor and this is just not the appropriate time to have this discussion. So we have this DNA extraction and hold where the DNA is actually held, but this requires a placental biopsy on the fetal side. And please do not send fetal skin. And this needs to be in the cytogenetics media, which is here. I have a picture, and this is the orange top with the pink fluid. And this is to be sent immediately to the central lab, not to pathology. The placenta will go to pathology, and if the patient opts for autopsy with the fetus as well. And then again, providing a post-discharge referral for PDC genetic counseling. Our FTC genetic counselors are robust and they'll be taking care of a lot of this, but our genetic counselors see all of our patients to describe some of the common genetic assessments. The karyotype, which can be ordered, it's not the routine standard of care, but an abnormal karyotype can be found in 16 to 13% of stillbirths. But we know that rate of karyotypic abnormalities are directly associated with anatomic abnormalities. The only thing with karyotypes is that it requires live cells, which brings us to our first line test, which is the chromosomal microarray. This is really what should be ordered in all patients who desire genetic workup. And this does not require live cells, so the culture rate is higher. But every patient should know that there are possible results of positive, negative, and uncertain significance. The genetic counselor will talk to them about all of this. This really is the genetic counselor's wheelhouse, these are just some clinical pearls for just you to describe these to your patients. But all of the results will be discussed with genetic counseling. The limitations are it can be costly and the inability to detect balanced genetic changes. Which brings us to the next genetic testing. I don't know, this is a lecture on its own, so I want to be brief, but exome and genome sequencing. Here at UCSF, we offer genome sequencing, which our genetic counselors talk about, but whole exome sequencing is sequencing of all the protein coding regions of genes in the genome. Whole genome sequencing is sequencing of all protein coding and non-coding regions of the genome. We, the genetic counselors, if there is uncertain significance or positive results or negative results, our genetic counselors will talk to our patients about whole genome sequencing. And this is really offered to patients who qualify at UCSF. And the reason behind this is that there have been some studies. There was a study in 2020 that was published in the New England Journal of Medicine, which did show that there's 246 cases with no clear cause of stillbirth, including a normal karyotype or microarray. And the whole exome sequencing led to an additional 8.5% of a likely causal molecular diagnosis. A couple more is antiphospholipid antibody syndrome. So these are this is a autoimmune thrombophilia, and the presence of the antiphospholipid antibodies. These should be ordered on all patients. The prevalence accounts for 5 to 15% of unexplained stillbirths. There's a specific diagnostic criteria for people to be either diagnosed with this or not, but this would be the first step to getting to that diagnosis. And the reason why I say this is because it will inform us for future pregnancies, and patients would be required Lovenox or low-dose aspirin in the next pregnancies to reduce the risk of adverse pregnancy outcomes. And of course, the KB tests, Kleihar-Bethke test, which is a test to assess for fetal maternal hemorrhage. Fetal maternal hemorrhage occurs in 4% of all stillbirths, so it's not nothing. And this is a very simple serum test that we'd like to order before the delivery. And this is a reliable method for identification and quantification of fetal maternal hemorrhage. But really, to summarize, not one size fits all. However, those tests that we just discussed should all be ordered for all patients who we see for a stillbirth. Now I just want to pass it off to our parent voice.
So I know these are really tough conversations that we have when someone loses a baby, and I encourage you to lean in and step forward rather than to lean back and step away. And I know that that's tough, but as a parent, you're really invited into just a tender and tragic time with us. Ultrasound is often considered ground zero. A lot of the focus is on labor and delivery, but I always turn people to ultrasound. And it's really where a parent's journey sometimes begins in saying hello and goodbye to their baby. And your role as a sonographer and in doing ultrasounds is often underestimated. I asked 15 stillbirth parents to describe in 3 words their ultrasound experience. And as you can see from this list, it's pretty daunting the way that they remember finding the news that their baby has no heartbeat. For ultrasound advice, I would say that my #1 complaint that I hear from parents is that they were left alone after they found out that their baby's heart had stopped beating. And I think that's a tendency to give them some time. But as a parent, and from hearing many parent stories, I would say don't do that. I know sometimes you have to leave to go get someone else, but just, I think, looking the parent straight in the eye and saying, I am not going to leave you. I've got to find someone, but I will be back. I will sit with you is so important. So they don't know what they want. They are immediately in shock, and not leaving them, even if you sit in the corner on a chair, don't leave them. If confirmed saying like, I'm sorry, the baby's heart has stopped beating and your baby has died, you have to use specific words for them to know what has happened. A handoff to mental health is very important, and follow up. They will not make the call, so follow up with them. If something is wrong, parents want to hear it straight. I know there's regulations with sonographers, but if possible, they want to hear it straight, especially in a pregnancy after loss. They watch sonographers like a hawk. They know what's happening. They're educated on ultrasounds. Emotion is okay and appreciated. Every single parent says this. It's okay if you cry with me. Don't say that you don't have to. And then avoid medical terms and follow the parent's lead on what they say. I want to talk about before a baby is stillborn, when the mom is in labor, if she has time and it's not an emergency situation, provide information with a comment that you'll return and provide further information. In my situation, I was asked once, do you want pictures? I said, no. Why would I ever want to remember this? Do you want an autopsy? No, I don't want an autopsy. I was never asked again. And I think it's important to realize that the situation is fluid and can change. And if you say, I'm going to provide you with some information, I'll be back and talk about it, it's okay. You're not pressuring them. You're working with trauma brain that they have. And so keep that in mind. Control the room. A lot of times there's a lot of people that show up for these families. And if there's important conversations or decisions to be made, clear the room. I know it's uncomfortable, but clear the room. Sometimes parents look to their parents and their biases are part of their decision, and there's a lot of regrets later. Clear the room and sometimes just give them time with themselves and the baby. Remember the non-birthing partner, they are experiencing things in a different way and in a tragic way as well. And then watch for grief with other family members. So often I have provided support for grandma in the room who had a loss and was never validated in her loss. I get her number, I follow up, and I get her resources after. After a baby is stillborn, do not be scared. Seeing a deceased baby is difficult. Loving a deceased baby is not. You set the tone, time slips quickly, and you have the honor of helping a family saying hello and goodbye. You will be remembered forever. They will remember you saying their baby's name. They will remember you forever. Say the baby's name often if they wish. They'll remember your voice saying it. Speak to the baby. If I'm in with a family and I'm moving the baby or wrapping him in a blanket, I talk to him. I humanize him. I'm like, hey, buddy, I'm just going to move you over here. We're going to put you in this blanket. Oh, you have the cutest little toes. You know, you're so sweet. I'll ask mom if I can hold her baby, and I model what she needs to do, because no one knows what to do with a dead baby, including the parents. So we rely on you to teach us what to do with our baby's body in the limited amount of time that we have. I explain appearance, including skin transparency, skin slip, lip color, mouth appearance, fluid leaking, temperature, color changing, cuddle cot. It's not going to scare the parents. They see their baby. So it's important to explain to them, this is the situation, and normalize it. This is what a stillborn baby looks like. And he's beautiful. So be cautious how you speak around siblings. If you say this baby was born sleeping or born still, there's issues with siblings when they go home. They're trying to process the death and they are scared to go to sleep. So be cautious of what you say around siblings. I change blankets and pads often if the baby is weepy, and I keep everything. I keep everything and I give it to the parents. Everything that baby touches, I keep. So parents can make the decision whether they want to keep it or not. I keep everything. Know that parents rarely read the take-home information that you give them in the packet. Very rarely do I meet a parent. In fact, the parents we talked to yesterday that are doing our training, it's tough. We don't read that packet. Sorry. I know there's important information in it, but I probably opened it 15 years after my son had passed. Autopsy conversations are difficult. We're going to talk about this. Consider someone, peer support that's been through it, to talk about autopsy as well. What to say when a baby dies. There are some phrases that are super important. I love, some parents find it comforting. Some parents find it comforting to hold their baby or do skin to skin. Some parents find photos comforting. Some parents find it's a great phrase to memorize to get you started in a conversation. Often parents make memories by. Often's a great word. I wish we didn't have to have these conversations today, but it is possible to take photos now and look at them when you're ready later. Some parents regret not having photos at a later date. This decision gives you options. I'm going to leave a box of tissues here. Your baby's nose may leak a little fluid as we move her around. It's perfectly normal. We'll just wipe it away with this tissue. I want you to be prepared in case it happens. It will be okay. Does he look like your children or other family members? I tell the story about a dad, the baby's toes were like this. They were so cute. And I'm like, oh, she has the cutest toes. Dad in the corner, who was not interacting with anyone, flips the shoe off, flips the sock off, runs over. He's like, those are my toes. And when I left that room, Dad was holding the baby and still without his shoe and sock on, comparing toes. So I look for ways to try to involve them, what not to say. We know this list. Never start a sentence with the word at least. That's my advice. This list is horrible. I've heard every single one of them. How to speak to parents about autopsy and testing. Rather than saying, do you want your baby to have an autopsy? No one wants their baby to have an autopsy. Instead say, I'm going to give you some reasons why I think an autopsy is an important option for your family. I will leave some information with you and come back and speak again and answer your questions. You have time to think about this. The testing that you choose for your baby is up to you, and you'll have many options and many levels. An autopsy is like a surgery. Your baby will be treated respectfully. They can associate with surgery. Give the name of the pathologist. I carried Jess Comstock's picture. She's a mom. She has 3 kids. She's great. She's really funny, and she respects the babies. You can send a stuffed animal to the autopsy with your baby. This is how I talk to parents. Even if the autopsy does not find a specific cause, it rules out enough to give answers as well. And that's really important to remember. And then the research and data that comes from autopsy findings can help other families who find themselves in these situations. And this is a way to honor your baby's life. You are going to love me for this QR code, and we'll send it out. But this is an autopsy decision aid that one of our researchers has developed. It is phenomenal because it puts the pressure on the booklet and off of the clinician having the conversation. It takes you through a full autopsy, partial autopsy, look at it. It's a really cool resource. We have a lot of resources on the Utah Stillbirth Center of Excellence under the resource tab. Triggers, parents' fears are valid. Even in different situations and losses, always validate. Fetal movement in pregnancy after loss brings comfort and a lot of anxiety. People have Dopplers and they use them 15 to 20 times a day sometimes. So it's complicated. Ultrasound are never routine, and clinic visits are never routine. PTSD is a real thing for pregnancy after loss. So watch for triggering dates and milestones. And then the best practice is just to skip assumptions and ask in a respectful way. Do you want me to talk about your baby who has died, or use their name? Reassure parents in pregnancy after loss that they are doing everything possible in that moment to provide a safe environment for their baby. I work in our pregnancy after loss clinic, and I tell parents, you are doing great. Right now, your baby is safe. You have a huge team behind you. I can't make promises, but I can tell them right here, right now, your baby is healthy and you're doing great. You're a great parent. So no false reassurances, but also they need reassurance. I know pregnancy after loss can be scary. You're doing great. In conclusion, I want to say that this is me in a picture with one of our moms who had 9 losses, and I was her photographer at her birth. And it was the most joyous cry we had ever heard in that delivery room. So I want you to know, as families, oftentimes you see us broken in our worst moments, but that we do heal and we come back and we have a place at this table with you. We become very intentional parents. We raise empathetic kids. Our kids are cool. They have siblings who have died. They're empathetic, and they're just, you know, probably a little weird, but really cool. So we eventually heal and thrive. We fight as advocates. We participate in lead research, and we volunteer as peer supporters. I want you to know that we do see you, and we appreciate you, and we remember you. And I want to thank you from all the parents who have been through this. We may not say it at the time because we're in the worst day of our lives. If I could relive it again, I would do it because I would do it so differently. And so what you do is important, and you help us for the rest of our lives. So from all the parents, I want to say thank you.
Thank you. I also want to say thank you as well. Thank you for being here today in person, and for those of you on Zoom. I also want to just to give an acknowledgement to, this is my patient, Sarah, and her husband, Brian. People took care of her, but her and Brian had a baby that had a category 3 fetal heart tracing and was transferred to UCSF with an emergency C-section. Their daughter, Leah, died after a month in our NICU, and they came back for their second pregnancy with baby Emmy here. And she is also just so grateful for all of the care that she received at UCSF. So you guys are all amazing. So thank you for being here as well. And we'll take questions. Any questions? Yes. Oh, I'm going to repeat your question. So
Yeah. go ahead.
Suzanne asked if we have scripts, especially for immediately delivery, because we know at that point, many parents are looking for an immediate answer of why this happened. And if we have scripts with how to guide us on these conversations. I do not have a script, Suzanne, but do you guys?
We could get a script.
We can get a script. That's great. And, you know, I think that a lot of this conversation, we unfortunately had a patient who had a term stillbirth last week on labor and delivery. And I know that many of you here cared for this patient, and it was really challenging, and it was a really hard conversation to navigate. And I know that many, especially our trainees, really were affected by this patient. And I think this is a great idea and something that we can work with the network for developing.
I would say try to hold back on giving any sort of answer, because it just, a lot of those are not correct. And they will be clinging for every single word that you say. So, you know, yeah. Any other questions? Yeah.
Tushani.
What we can do with the ordering, but also I have a question about that MRI. Talk about autopsies and self-information for us to figure out, and maybe that helpful about that. But MRIs, especially when you have numbers that get here, when you're looking at those values or some findings on an MRI, is that like the same? Is that the same amount of additional information that an MRI was over compared to?
That's a great question. Tishani asked if the MRI, a lot of our patients get level 2 ultrasounds here in our PDC, and with the MRI provide more additional information for those patients. I would say some organ, it depends on the organ system, right? Like it depends on the sensitivity. So it does depend on the organ system that's affected, and additional things that some people get a level 1 ultrasound or a level 2 ultrasound at their anatomy ultrasound, and then really we don't look at the fetus again. So there could be additional benefit yielded especially if a person has only had one anatomy ultrasound and no other imaging since that time, because like congenital diaphragmatic hernias pop up and these things aren't diagnosed until later sometimes.
I would say too, like I've never met a family that regrets having an autopsy. I've met dozens of family who regret not having an autopsy. So
That's a great question. And when the question was about biobanking, and if this is something that our network has thought about, and actually at Utah, they're extracting blood from like blankets after stillbirth and trying to do trio sequencing to really understand if there is a genetic component. So they are extracting different like samples. So I think biobanking, I don't know, is Bob Silver is doing this. Yeah, I'll have to confirm with Bob Silver, but I think that's a great idea. And I know that they're actively trying to figure out how to get ways to extract DNA that has not previously been stored.
And I think paternal sampling is so important because as a mom, you feel guilt and shame that you did something, and really there's 50% so we are doing paternal sampling as well. And we should. It takes the pressure off of the mom.
Naseem, and then we're going to wrap up. Dr. Sobani. The first question was about MRI and what's causal versus what is a consequence of. And I don't know the studies on that. I haven't seen any. And then the second question, actually, Stacey works with the peer support group at Utah, and actually the Utah research is robust on stillbirth. So actually she was going to just speak briefly because we have to wrap up.
Yeah, I work in our pregnancy after loss clinic, and I'm the one that introduces the research team. So a soft handoff to the research by a parent makes all the difference. Our numbers have increased, and I think just educating parents that research takes years and it's not an immediate answer. Immediate answers come with placental and autopsy, but research and helping battle the causes of stillbirth takes years. And I think that education with parents is really important. But this is where Dr. Silver wants parents' involvement 50 to 100% in research. Giving data, coming up with ideas and presenting it to patients. And it's powerful. We can say things that other people can't say. And that soft handoff of trust is immediate. So I think it helps having a parent.
Which we're hopefully going to be developing in the future. I know that we need to wrap up because we have our department meeting. So thank you for attending. Tylenol in pregnancy in the Sapphire room.
Faculty meeting right now. Thank you. That was so good. That was very hard.